This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Welcome to the Neurology podcast. This is Alison Christy from Providence Health and Services in Portland, Oregon. Today I'm talking with Wallace Brownlee from Queen Square MS Center, University College London, on his article investigating whether dissemination in time is essential to diagnose relapsing multiple sclerosis. Thank you for talking with me today.
Thanks very much for having me, Ali.
So the diagnosis of MS, we all know, requires dissemination in space and dissemination in time. Your paper aims to essentially get rid of this requirement of dissemination in time. So why throw that out?
So dissemination in time has been a cornerstone of MS diagnosis going back 5, 6, 7 decades. And it's really a hangover from the pre-MRI era where we only had our clinical skills, our history, the clinical course to try and decide whether someone had a relapsing chronic disorder versus something that was likely to be monophasic. And with the advent of modern MS diagnostic criteria, or the McDonald criteria, named after Ian McDonald, these have been around now since 2001. MRI took on the role of providing evidence for both dissemination in space and dissemination in time. But that need for dissemination in time, or DIT, has really been questioned in recent years. And that's based on a number of different things. So the first thing is that when we see a person with a new diagnosis of multiple sclerosis, they might have 10 or 20 brain lesions on MRI. And I think the chances that all 10 or 20 lesions formed at exactly the same time is very low. Of course, we've got no way to prove that, however. Another thing that's happened in 2017, the McDonald criteria were updated, and it was found that actually if you've got CSF-specific oligoclonal bands, that's unmatched IgG bands in the spinal fluid that aren't present in the serum, then that's just as good as having a gadolinium-enhancing lesion or a new T2 lesion at follow-up. So that can be an alternative way of providing evidence for dissemination in time. And I think what's really happened since then, in the last 6 or 7 years, that many of us use MRI and a lumbar puncture to make the diagnosis of MS, and we no longer feel that dissemination in time is essential to make that diagnosis.
So based on this study, what do you see on that first MRI after a first demyelinating event that makes you think it's very likely that a person has relapsing remitting MS?
So what we were interested in this study was to try and determine whether if a person has high fulfillment of dissemination in space criteria, meaning lesions in 4 or 5 regions typically affected in MS, so that's the periventricular, juxtacortical, infratentorial regions of the brain, the spinal cord, and the optic nerve, which is expected to be included in future iterations of the McDonald criteria. What we were trying to understand was if you've got high fulfillment with lesions in, say, 4, all 5 of those regions, is that enough to make a diagnosis of MS? Do you need any other supportive evidence, like a lumbar puncture? And what we found is that actually if you've got involvement of 4 of these typical regions, or you've got a full house, you've got involvement of all 5 regions, actually that had a very high specificity and positive predictive value for a diagnosis of MS. It wasn't essential in those patients, or it didn't appear to be essential to be seeking additional evidence for dissemination in time, whether that's in the form of MRI or a lumbar puncture looking for oligoclonal bands.
And what about visual evoked potentials? You talk about those in the paper as well.
So we use visual evoked potentials in this study as a way to determine whether a person had involvement of the optic nerve. So unlike other parts of the nervous system, the brain or the spinal cord, where MRI is our gold standard for detection of a lesion, we've got different ways where we can assess the optic nerve. We can use MRI, we can use optical coherence tomography or OCT, and we can use VEPs. And we particularly liked the prospect of using VEPs in this study because that's something that's really widely available to many of us through neurophysiology departments at our hospitals, or for those doing neurophysiology in their practices, evoked potentials are fairly easy to acquire. And so we use visual evoked potentials to try and identify whether patients had either symptomatic involvement of the optic nerve, that might be in a patient with acute optic neuritis, or an asymptomatic lesion in the optic nerve that can help us establish dissemination in space. And our study and previous studies have found that maybe 1 in 5 patients with a non-optic neuritis presentation do have involvement of the optic nerve on neurophysiology studies with evoked potentials.
You had an algorithm in your paper to use for patients in clinic after a first demyelinating event. So walk me through how I could use this in clinic.
After putting all our data together and evaluating the performance of an MS diagnosis based on dissemination in space alone, we tried to put forward an algorithm that actually could be useful to people evaluating patients with suspected MS. And I guess the first step when applying any kind of criteria for diagnosing MS, and one that remains essential, is to exclude other conditions. So we need no better explanation for our patient presentation. So investigations need to be done to exclude those conditions, and that will depend on the clinical presentation, the clinical setting. Is this relapsing or progressive disease, the person's age? All of those things will impact on the other conditions we might think about. As a next step, we suggested looking at MRI and beginning with MRI of the brain and spinal cord, which I guess is pretty commonly acquired in the context of someone with suspected MS. And if there are lesions in the periventricular, juxtacortical, infratentorial, and spinal cord regions on that MRI, if all 4 regions are involved, we actually found that's enough evidence to say this is multiple sclerosis. If there's involvement of a fewer number of regions, say the person's got periventricular, juxtacortical, and spinal cord lesions, so they don't quite meet that 4-region threshold, we've suggested that as a next step, you evaluate the optic nerve. And in our centre, the easiest way to do that was with visual evoked potentials, but depending on where you work, it might be optical coherence tomography instead. And if the optic nerve is involved and we've got various criteria for deciding whether OCT or VEPs are abnormal, then you might make a diagnosis of MS at that point. If there's only involvement of 2 regions, 2 of those 5 regions typically affected in MS, then you still need to seek out evidence for dissemination in time or consider doing a spinal tap to look for oligoclonal bands. And if either of those are positive, then a diagnosis of MS is made. If a person doesn't have evidence for dissemination in space, or the person has negative bands, dissemination and time criteria on MRI are not met, then clearly we need to continue to follow those patients for evolution to MS in the future.
Many of the patients in the study did present with optic neuritis. Do you think that changes the applicability to other populations?
About a quarter, or some studies up to 30% of patients with MS, their initial symptoms are with an optic neuritis. And in our study, there was definitely a overrepresentation of people with optic neuritis. So about 80% of the patients we studied first presented with optic neuritis, and that's just to do with how we recruited our cohort. I think there is a potential limitation here that some studies suggest people with optic neuritis have a more favourable prognosis or are less likely to have MS than, say, someone presenting with transverse myelitis or an inflammatory brainstem syndrome. On the other hand, the patients we studied with optic neuritis, they had a high rate of asymptomatic brain MRI lesions, so over 80% of them had an abnormal brain MRI presentation. So this was a group where MS was likely or MS was suspected, rather than a group of people, say, with optic neuritis from other causes.
Do you have any thoughts of how this might apply to my population, which would be a pediatric population?
So we didn't evaluate this algorithm or test these proposed changes in a pediatric MS cohort, and I think that's definitely an opportunity for the future. What I would say is that the pediatric MS patients that I see actually tend to have quite florid MRI scans at presentation. So compared with adults, they've often got lesions in all 4 of the regions. We don't know so much about the optic nerve in patients with pediatric onset MS. That hasn't been looked at as carefully as in adults. But I think after excluding other disorders, particularly MOGAD in a pediatric MS population, I think there's no reason that an algorithm like this or basing the diagnosis on the basis of dissemination in space alone isn't reasonable.
So what are the next steps for this project?
We hope that this data will be useful to inform the revisions to the McDonald criteria, which anticipated in 2025. And these will, of course, change how we diagnose MS. We've also run a similar study looking at the diagnosis of primary progressive MS on the basis of dissemination in space alone, without the need for evidence for dissemination in time or a positive lumbar puncture. And we found also in that patient population that it's feasible to diagnose MS on the basis of DIS alone. I think there's an unmet need now to test this approach in older patients or special patient populations. That might be older people with MS, those with comorbidities, pediatric patients, as we've discussed, and also thinking a bit more about patients with radiologically isolated syndrome. So they weren't included in this cohort. And we anticipate again that in 2025, they will be included under the MS diagnostic umbrella. And we need more information about how to more efficiently diagnose MS in this group.
Fascinating. Thank you for talking with me today.
Thank you, Ali. It's been a pleasure.
That was Wallace Brownlee from Queen Square MS Centre, University College London, on investigating whether dissemination in time is essential to diagnose relapsing multiple sclerosis.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.